Good afternoon to one and all. Today we are beginning with the topic glaucoma. The first part of the session will be primary glaucomas. To begin with, I'll start with the introduction. Glaucoma, you must remember the definition. Glaucoma is a chronic, progressive optic neuropathy caused by a group of ocular conditions which lead to damage of optic nerve with loss of visual function. Most common risk factor, increase in IOP, and it is modifiable. Must know. A sustained increase in intraocular pressure may be due to increased formation of aqueous humor or a raised pressure in the episcleral veins. Raised intraocular pressure is essentially due to an increased resistance to its drainage through the angle of anterior chamber. Either you produce more and exit less, or you produce less and have a low IOP. There are two aqueous flow pathways. I guess you all know by now, from optometrists to UGs to PGs. There are trabecular meshwork outflow 90% and uveoscleral 10%. If outflow through trabecular meshwork is blocked, drainage occurs through uveoscleral outflow. But these alternative channels are not efficient and they are incapable of dealing with sudden changes of intraocular pressure. These are the basics you must know. The definition of glaucoma is most important in this introduction page. Coming to pathogenesis, there are various theories. Two main influences are mechanical changes due to rise in IOP, vascular perfusion of the optic nerve head. Coming to mechanical changes, the coats of eye can withstand fairly high intraocular pressure except the lamina cribrosa. Lamina cribrosa is a sieve-like structure. It is fenestrated region through which optic nerve fibers enters the eye. Here the nerve fibers are supported by the glial tissue and have to bend over the edge over the disc. A raised IOP causes mechanical pressure over the lamina cribrosa. Don't worry, I'll give you all the notes, handwritten notes. For now, just chant the Parsons and FAQ. You will get a hang of it. Mechanical pressure on the lamina cribrosa altering the capillary blood flow and decreasing the exoplasmic flow, leading to exoplasmic stasis. Later, backward displacement and compaction of the laminar plates narrows the openings through which the axons pass, directly damaging the nerve bundles. You have to understand the basics before you understand the concept of the disease. You got to know about the mechanical changes. Next, we have the vascular perfusion. These are the two main pathologies. The perfusion of the optic nerve may be affected because of lack of inadequate autoregulatory mechanism. This mechanism we read in first year physiology. A substantial rise in intraocular pressure can also decrease the capillary blood flow due to mechanical capillary mechanical compression of the capillary blood flow due to mechanical compression of the vessels at the lamina cribrosa, or a decreased flow in the annulus of Zinn, which supplies nutrition to the laminar and post-laminar optic nerve head. A fall in perfusion pressure at post-laminar head may additionally be caused by systemic factors such as hypotension, to be noted, not hypertension, vasospasm, and acute blood loss. Other factors include, these are not much important. It is believed that patients with POAG have susceptibility to damage in some part because of the presence of larger openings in the lamina cribrosa that allow for the greater mechanical displacement of the nerve fibers coursing through. So far, so good. I hope you get through it. You need to revise. Glaucoma is a tough topic. Dysfunctional axonal transport. As I said, axonal stasis. Due to these mechanical or vascular changes leads to fewer tropic factors reaching the ganglion cells, which causes damage and eventually the death of ganglion cells, which triggers apoptosis. As the loss of nerve fibers extends beyond the normal physiological overlap of functional zones, visual field defects become apparent, seen on perimetry or confrontation perimetry. This loss of nerve fibers is seen to occur initially and predominantly at the superior and inferior poles. Again, a question for Viva. The normal distribution of nerve fibers in the retina is such that polar loss of nerve fibers translates into loss of function in an arc above and below the macular area, ending in an horizontal line nasally with neither crossing it. These diagrams are to be meant for being drawn in exams. This cannot be drawn. I'll give you a simplified diagram. Coming to the diagnosis. Diagnosis of glaucoma is made after looking after combination of clinical signs, which includes optic nerve head evaluation, visual field anomalies, changes in intraocular pressure. It's a triad. IOP, visual field, optic nerve. Do not forget this. It is a must know. The type of glaucoma is determined by the clinical features and the status of anterior chamber angle as determined by gonioscopy. Gonioscopy is an art, and it is an art which is difficult to master. Step by step, as you go on, you will get to learn about gonioscopy. Teaching gonioscopy is beyond the scope of this lecture. A diagnosis of POAG can be made if at least two of these three abnormalities are detected. I have mentioned you the three. In acute and subacute PACG, primary angle closure glaucoma, and secondary glaucomas. Secondary glaucomas we will discuss in our next lecture later in the night. The presence of raised intraocular pressure is enough to make the diagnosis of glaucoma. Coming to optic nerve head changes. You have to know about this. You have to know about the signs which you have to look for in the disc. I- Optic nerve head changes is associated with glaucoma are thought to be seen prior to the development of visual field loss. Normal cup disc ratio is 0.3 is to 1, that is subjective. The following changes are commonly seen in optic nerve head in glaucoma. Mark my words, I'll be highlighting. Just remember the word asymmetry between two eyes, notch or thinning of the neuroretinal limb, enlarged disc ratio, pallor, disc hemorrhages. Mind you, disc hemorrhages signify normal tension glaucoma. Vascular signs suggestive of cupping, such as bearing of circumlinear vessels and overpass of central vessels, and lastly, not such important, parapapillary atrophy. Next, visual field abnormalities. Again, I'll be highlighting the points observed initially in Jerum area 10 to 25 degrees from fixation and correlate with the abnormalities seen in optic nerve head. The common field defects, I know you are well versed with it. Just get the names right and you are through the exams. Paracentral scotoma is the first, Rene's nasal step, sedal scotoma, arcuate scotoma, double arcuate scotoma, end stage or near total field defect with only residual temporal island of vision which occurs at the last stage. How do you diagnose a glaucoma field defect? Let's see. You do a perimetry. Visual field loss in glaucoma is considered significant in one of the following is seen. If the GHT is abnormal, glaucoma hemifield test is abnormal. I'll be taking a class on perimetry for 4 to 5 hours. Need not worry about it. Just for now, mug it up. Three contiguous non-edge points on the pattern deviation plots within the Jerum's area have a probability of less than 5% of being seen in normal population, one of which should have a probability of less than 1%. Coming to the third one, the corrected pattern standard deviation CPSD should have a probability of less than 5% confirmed on 2 consecutive tests. This is known as the Anderson's criteria. $1,000 question, it will be asked in exams. Glaucoma hemifield test compares the sensitivity of 5 clusters of points above and below the horizontal midline which resemble the nerve fiber bundle patterns. This type of loss is common in glaucoma and is usually asymmetrical above the horizontal meridian. The analysis is identified as abnormal if one or more of the 5 regions demonstrate asymmetry. The key being asymmetry. Asymmetry in the pattern of perimetry. Just remember it like that. It is regarded as borderline if the asymmetry is within 1% probability level for all 5 regions, but beyond 3% probability level for one or more regions. At least two such fields plotted on different occasions are required before the diagnosis can be made. Presence of a clinically significant visual field defect is determined by carefully interpreting the visual fields. One method of categorizing the visual field defects in glaucoma is based on the value of mean defect. There are many patterns. In total, we have 10 patterns for perimetry, which I'll be taking a separate class on. It will be easy for you. For now, just have it as a rote learning. A value of 0 to 6 signifies a mild defect, up to 12 moderate, and more than that severe. Early detection of glaucomatous visual field changes is now being tried in a number of ways, such as the use of short wavelength light stimuli, frequency doubled stimulus, contrast detection technique. Multiple techniques have come up, and we go for swap. Short wavelength automated perimetry is the thing to do for now, which presents a bright yellow background to depress the sensitivity of the green and red cones. We have three cones RGB, red, green, blue, allowing the sensitivity of short wavelength system to measure using a large blue target. Newer modalities have been coming up. We are not going through these. We'll discuss in recent advances. Coming to intraocular pressure, the most important factor and most modifiable. Level of intraocular pressure shows a polygenic inheritance. All these are not required. There is a diurnal variation with high pressures commonly in the morning. Superimposition leads to increase. Simple है, मॉर्निंग एंड इवनिंग देर इज अ डिफरेंस. मॉर्निंग में ज़्यादा है, सोए हुए हो ज़्यादा है. देर आर कंटिन्यूस वेरिएशंस विथ कार्डियक एंड रेस्पिरेटरी साइकिल्स. rubbish point not needed. With exercise there is a decrease in IOP. With Valsalva there is an increase in IOP. Pani piyo, there is an increase in IOP. So one thing we must remember, while exercise we have a low IOP, and rest of the whole of this world, whatever we do, we have a high IOP. Types of IOP: primary, secondary, congenital. Coming to primary adult glaucomas, primary adult glaucomas have primary open angle and closed angle. Today's motto for this lecture 1 in glaucoma is POAG and PACG. To start with, POAG. Mark my words, whatever I tell you, if you can reciprocate in the exam, you will score fair enough. Primary open angle glaucoma. The answer is in the word itself. The angle is open, but still, why do we have glaucoma? Adult onset, bilateral. Glaucoma is not unilateral. Symmetrical. Angle will be open, that's why known as open angle glaucoma. Optic nerve head changes will be there. Visual field changes will be there. IOP will be more than 21, as the triad I mentioned before. Mark it up. It is the commonest form of glaucoma in Caucasians and Africans and constitutes about half the primary glaucoma seen in Asians and Eskimos. Age group 40. It is hereditary. Runs in family. Even I have a family history of glaucoma. The inheritance is thought to be multifactorial and polygenic, with many genes contributing, although genetic analysis in some families with juvenile POAG identified a specific link to long arm of chromosome PQ. Chromosome PQ. Chromosome 1. Probably a question in future for MCH exams. Genetics in ophthalmology. Patients who develop glaucoma probably inherit a variable number of genes. These genes appear to influence the height of intraocular pressure, the facility of outflow. These are the perimetry things. I'll be explaining perimetry in detail, don't worry. Diabetes mellitus, myopia occur more frequently in persons with glaucoma. This is a question. An intraocular pressure less than 21. Can you tell me the normal intraocular pressure? There are many schools of thought, but my take is 12 to 21 mmHg. An IOP of less than 21 mmHg is recorded repeatedly in about 15% of patients with all the other features of POAG. This condition is labeled as normal tension glaucoma. Normal tension मतलब IOP normal, visual field and optic nerve not normal. Ocular hypertensives, IOP raised, visual field normal, optic nerve normal. You have to differentiate. Patients with optic nerve had changes suggestive of glaucoma but without raised IOP or visual field changes are suspected POAG suspects. Again a question. These all are questions, be it entrance exam, be it theory exam, be it a Viva exam. Coming to pathogenesis. Just a moment. The rise in IOP in POAG is related to increased resistance. Resistance to what? Outflow. बाहर नहीं निकलेगा पानी तो अंदर तो प्रेशर बनेगा, especially at the juxtacanalicular region. Angle of anterior chamber has three parts: uveal meshwork, trabecular meshwork and juxtacanalicular meshwork. The juxtacanalicular meshwork provides the maximum resistance to outflow of aqueous. To be noted, this is a question of basic sciences. Coming to clinical features, simple, easy, headache, frequent changes of glasses. These are the summaries, you can check on it. This is a close summary about primary, secondary and congenital. We'll not get into it. We'll go step by step. Noticing a blind spot or a scotoma in the visual field, difficulty अंधेरे में देखने में दिक्कत होता है. What are the signs? Increased IOP, difference more than 8 mmHg, CD ratio more than 5.5, asymmetry of more than 0.2 between two eyes, narrowing, notching, disc hemorrhage, abnormalities of blood vessels. This is very important part. You must know it. Visual field changes. Glaucoma is based on only three things. My dear students, IOP, visual field, optic nerve head changes. So whatever you do should be based on this thing only. Visual field changes, we have done. IOP we have done. We have done the optic nerve head changes. Now coming to RNFL changes, retinal nerve fiber layer changes, which can be seen extending from optic nerve head in the form of arc in a superior and inferior poles of disc. These are best appreciated after dilated fundoscopy. Management. How do you manage POAG? This is an irreversible disease. Medication has to be given lifelong, and it is therefore imperative to detect glaucoma early so that visual morbidity can be avoided. Patients at risk for glaucoma, those with an affected first degree relative, diabetics, myopes, earlier than after the 40 years of age, should be examined regularly. As it is chronic, insidious disease, close follow up is mandatory. How do we monitor? Routine checkup of intraocular pressure, perimetry for the visual field, optic nerve head evaluation, and gonioscopy for the angle assessment. Glaucomatous damage generally tends to occur over years, not days to weeks. This is a long term process. Long term. The following features should be documented. IOP must be recorded when the patient comes, and each and every visit the patient must have been recorded the intraocular pressure. Optic nerve head damage must be evaluated with a dilated or undilated fundoscopy, dilated only after gonioscopy. Associated features like vascular disease, diabetes, and myopia must be checked upon. These parameters help to detect the range of intraocular pressure between which the target pressure can be set. This is one word which will get you through your exams. Target pressure. What is target pressure? Long term studies have shown that if the intraocular pressure is maintained between 16 to 18 millimeters of mercury, it leads to stabilization of POAG in most cases. Treatment options simple. Treatment is divided into medical and surgical. Treatment options are divided into medicine, laser, or surgery, which can be used to set the target pressure. Medical and surgical therapies to lower intraocular pressure are similar in glaucomas and are described at the end of the chapter. We will go through it everything. We will cover whole Parsons and Skansky. Don't worry about it. Medications are alpha agonist, beta blockers, carbonic anhydrate inhibitors, prostaglandin analogs, meiotics, many more so, and the newer drugs. Coming to laser therapy, there is SLT, selective laser trabeculoplasty, where laser spots are applied gonioscopically to coagulate the trabecular meshwork. Why we do it? To increase the aqueous outflow. This causes the collapsed trabecular beams to become taut. Keyword: increasing the space available for aqueous to drain out. It has also been observed that endothelial cells which migrate to cover the areas that have been subjected to laser therapy, change the biochemical properties of extracellular matrix in the trabecular meshwork. Very important point. Argon, diode, or frequency double Nd:YAG lasers have been used to apply 50 to 100 spots. 50 to 100 spots. Just a second. Allow me for a while. The laser spots, the size of laser spots will be 50 microns. 50 microns, and the angle covering will be 180 to 360 degree of angle. I hope you have to remember this, which will come in your exams. And the spots will be placed at the junction of the anterior and posterior trabecular meshwork, ATM and PTM. Junction of ATM, PTM, you place the spots. Size will be 50 microns. Angle will be 180 to 360 degree. As you all know, once we intervene and give a laser shot, there is a transient rise in intraocular pressure, which requires prophylactic treatment with topical apraclonidine. I would not suggest apraclonidine because it has a CNS suppression property. Rather go for brimonidine or timolol if not asthmatic. The intraocular pressure falls by an average of 5 to 7 millimeters mercury, but the effect is said to diminish over time. As I mentioned before, laser trabeculoplasty is therefore indicated if medications do not adequately control the IOP. So this was the end of primary open angle glaucoma. Coming to few questions from Arvind Eye Hospital. Let's see if we can answer it or not. What are the risk factors of IOP? I have already mentioned high IOP, myopia, diabetes mellitus, vascular disease, advanced stage, Caucasians as per Parsons, no gender predisposition. What is phasing? This is a new question. Make a note of it. Measurement of IOP at various times of the day and night. Causes of diurnal variation, fluctuation in production. Easy enough. What is the usefulness of diurnal variation measurement? Diagnosing, checking progression, checking efficacy of therapy, distinguishing normal tension glaucoma from POAG. Important one. Pathogenesis of glaucoma damage already explained. Mechanical theory, ischemic, vascular, loss of architecture. Everything has been answered already. What are the genes associated? This is a new one. I said chromosome 1PQ as per Parsons. Now we have myosin gene and optineurin gene. Make a note of it. This is a probably recent advance. Normal rate of loss of ganglion cells per year, not mentioned in Parsons, it's 5000 ganglion cells per year. How do ganglion cells die? Simple, apoptosis, second year pathology. What are the studies done in POAG patients? This you have to remember, just mug it up. 3 B's I call it: Beaver Dam Eye Study, Baltimore Eye Study, and Blue Mountain Eye Study. What is the importance of gonioscopy? To check the angles, and if possible we have to check it is progressing or not. From my side, this is the toughest and the most important question. How do you define target pressure? Target pressure is the pressure at or below which further damage or loss of ganglion cells is unlikely. Just mug it up. This will be there in your exams, theory, viva, practical, anywhere. How does normal tension glaucoma differ from POAG? I would like to mention one thing. If a patient has nocturnal hypotension, he is predisposed to normal tension glaucoma, and this one line is enough to differentiate between NTG and POAG. Now let's see what the book has to answer. NTG is a disease of exclusion. Very well. Mean IOP will always be less than 21. I told you the tension will be normal and there will be no other changes. Again, the next question: what are the sites of maximum resistance to outflow in POAG patients? I told you the parts of trabecular meshwork: uveoscleral, trabecular, and juxtacanalicular. Juxtacanalicular part of trabecular meshwork has the maximum resistance in the outflow of aqueous. Again, an important question to be known definitely. What are the other reasons behind trabecular outflow resistance for elevated IOP? Simple, if there is obstruction of collector channels by the glycosaminoglycans. What are the histopathological changes? This is a new question apart from Parsons. Histopath changes. Make a note of it. Alteration of trabecular beams in the form of fragmentation of collagen, thickened basement membrane, fused trabecular beams, narrow intertrabecular spaces, narrow collector channels, decreased number of giant vacuoles. This is an important question. This is not mentioned in Parsons. While we get into Kansky, then we might get this answer. But for now, I am trying to mix Parson and frequently asked questions. Optic nerve head changes, very important, and it will come in the exams. I'll just highlight the main points. Papillary changes. Papilla means optic nerve. So the papillary changes means changes in optic nerve. There will be enlargement, narrowing of the neuroretinal limb, cupping, saucerization. If there is cupping, there will be saucerization. This is papillary changes. Coming to peripapillary changes, changes around the optic disc. Hemorrhages. Hemorrhages signify normal tension glaucoma. Changes in the nerve fiber layer, changes in size of the arterioles. Coming to vascular changes, nasalization and bearing of circumlinear vessels. Just Mug this up. Moving on. This is an easy one. The best method to identify optic disc changes is via 60, 78 or 90D lens. In our center in Shankar Netralaya, we use 78D. While I was in the government college, I used 90D. So I have the best of both worlds. What is the best method of documenting optic disc changes? Photographic evaluation. Why does cupping occur? This is an important question. Backward bowing of lamina cribrosa, elongation of laminar beams, and loss of ganglion cells. Loss of ganglion cells, why do they occur? They occur due to apoptosis of the neuronal cells. What is the main site of nerve damage? Lamina cribrosa, as we all know. Shape of NRR, it is you have to remember the ISNT rule. Maximum space in inferior zone, then superior, nasal and temporal. Even the cupping starts in this fashion as well. Normal cup disc ratio 0.3:1. This is an important question. Why are superior and inferior poles affected first? Because they have larger laminar pores. One word answer. Can cupping reverse? Cupping can reverse in children and young patients following lowering of IOP because of the elasticity of sclera. So the word is elasticity. Parapapillary changes in glaucoma, not such an important question, so I would omit it. What is bearing of circumlinear vessels? Another important question. Vessels that pass circumferentially across the temporal aspect of cup have been called circumlinear vessels. If they pass the exposed depths of the cup, they are bared. Bearing of circumlinear vessels is seen because as the cup recedes, it exposes the vessels. What is nasalization? You need to understand in glaucoma there are few words which the examiner will definitely ask. One of them being nasalization, barring of circumlinear vessels, normal tension glaucoma, target pressure, etc. etc. As the cup enlarges, the retinal vessels are displaced nasally. This is known as nasalization, as simple as that. What is the significance of disc hemorrhage? N number of times I have answered these in last 1.5 hours. If there is disc hemorrhage, it is normal tension glaucoma. It is a sign of active disease and they more occur in normal tension glaucoma. By now you should have got it by heart. Another question from the externals, what is saucerization? Occasionally the glaucomatous damage to the optic disc produces shallower background, bowing of the disc rather than excavation. This is called saucerization. How many ganglion cell loss should be there before visual field loss? I guess this is not an important question, but it's a fact based question. 25 to 30% loss of ganglion cells. What are the investigations? Name all the investigations: OCT, nerve fiber layer analysis, FDP, SWAP, and HRT. Is there any role of corneal thickness in POAG? The GAT, Goldman Appellation Tonometry, is accurate only in central corneal thickness, measuring 520. 520 microns is the normal central corneal thickness. Thin corneas have falsely low measured IOP. If it is thin, you give more pressure, so you get a false low IOP. They applanate less. Thick corneas have falsely high reading. This is a basic question, but many students get it wrong. What are the differentials? When you present a case of POAG, you are bound to be asked about the differential diagnosis of POAG. Pseudo exfoliation, remember P, pseudo exfoliation, P, again pigmentary, raised episcleral venous pressure. I would like to mention here elevated episcleral venous pressure is also caused by Sturge-Weber syndrome, where there is port wine stain. Just keep it in mind, you will have some extra marks. Again a P, post-inflammatory, then steroid induced and ischemic optic neuropathy. This is very important. What is SLT? I have previously taught you in Parsons selective laser trabeculoplasty, wherein double frequency Nd:YAG laser. What is normal frequency Nd:YAG laser? It has a wavelength of 1064 nanometers. In SLT, we use double frequency laser. Double frequency will have a wavelength of 532 nanometers, which is used to selectively target the melanin cells in trabecular meshwork. If there is trabecular scarring, in POG there is trabecular scarring, so miotics will not work because miotics have to constrict the pupil, but if the trabecular meshwork itself is scarred, then there will be no constriction and miotics will not be effective. Now we have to look into other causes for visual field defects apart from glaucoma. If there is pallor more than cupping, asymmetric disc chromatopsia, fields respecting vertical meridian, contralateral optic nerve head normal. These are the conditions when we will suspect intracranial lesions with visual field defects. Quite a high yield topic. Non-glaucomatous conditions mimicking POAG, chiasmal compression, AION, toxic optic neuropathy, hypotension. Must know. That's all from the introduction and primary open angle glaucoma. In the second session, we will be talking about primary angle closure glaucoma. Thank you.